Hello, I'm Dr. Ailey Kalapila from Emory University. In this National HIV Curriculum mini-lecture, I'm going to provide you with a brief review on the prophylaxis and treatment of histoplasmosis in people living with HIV. Now, this is going to be the outline of my talk. I will start with some background, followed by reviewing prevention of histoplasmosis. Then I will go over the clinical manifestations and how you make a diagnosis of histoplasmosis. And then I'll discuss the treatment options, followed by common side effects associated with medications, and then finally, a summary. Now, diving right into background. Histoplasmosis is an infection caused by the dimorphic fungus Histoplasma capsulatum. Now, by dimorphic fungi, what I mean is that these are fungi that can exist in two distinct morphologic forms. They usually exist as a mold form at lower temperatures and as a yeast form at higher temperatures. Now, Histoplasma capsulatum is found around the world. It is endemic to the central and south central United States, particularly in the Ohio and Mississippi River valleys, and you can also see infection elsewhere in the eastern U.S., as well as Latin America and the Caribbean, Asia, and Africa. Now, the main route of exposure is via inhalation, with subsequent dissemination from lungs to other organs. When individuals with HIV have a low CD4 count, typically less than 150, they are at risk for developing symptomatic disseminated disease when exposed to histo. Also, for patients with HIV who have a history of prior exposure to histo, you can see reactivation of latent infection if these individuals experience a significant decline in their CD4. And in general, a lower CD4 is associated with more severe clinical manifestations. Now, let's discuss how one can prevent histoplasmosis. So, in general, people with HIV who live in or travel to histo-endemic areas cannot fully avoid H. capsulatum exposure. But for patients who have a CD4 count less than 200, they should be advised to avoid high-risk activities, which include things like disturbing soil, cleaning chicken coops, handling bird or bat droppings, renovating buildings, or exploring caves. The Opportunistic Infection or OI guidelines recommend taking primary prophylaxis if individuals have a CD4 count less than 150 and are at high risk due to occupational exposure or reside in areas with hyperendemic histo. Hyperendemic in this case is defined as greater than 10 cases per 100 person years. Now, if started, prophylaxis can be discontinued once the CD4 is greater than or equal to 150 for at least 6 months and the HIV viral load is undetectable. Primary prophylaxis should be restarted or resumed if CD4 levels drop below 150. This is a table showing the drugs you can use for primary prophylaxis for histoplasmosis. The main prophylaxis preferred regimen that is recommended is the antifungal drug itraconazole. There is no alternative regimen that is recommended by the OI guidelines for primary prophylaxis. And as I mentioned before, primary prophy with itraconazole can be discontinued once the CD4 count is greater than or equal to 150 for at least 6 months and the HIV viral load is undetectable on a fully suppressive antiretroviral therapy or ART regimen. Primary prophylaxis should be resumed if a CD4 levels decline to below 150. Now, let's get into some more details on clinical manifestation of histoplasmosis as well as diagnostics. In people living with HIV with a low CD4 count who are not on ART, histo can have a wide spectrum of disease with more severe symptoms being seen at lower CD4 counts. Patients with advanced HIV can develop disseminated disease, which commonly presents with fever, fatigue, weight loss, and hepatosplenomegaly, and respiratory symptoms can be seen in about half of cases. GI symptoms such as nausea, vomiting, diarrhea, and abdominal pain are also frequent. Central nervous system and skin involvement can occur in up to about 20% of patients. Around 10% of those with low CD4 counts may develop septic shock and multi-organ failure. And abnormal lab findings can include things like cytopenias, high ferritin, markers of adrenal insufficiency, and occasionally you may be able to see intracellular yeast forms in white blood cells on peripheral blood smears. The detection of histoantigen in the urine is a highly sensitive and specific test that allows for the rapid diagnosis of disseminated histo in people with HIV, especially for those patients with a low CD4 count. Now, in general, serologic antibody tests are less useful in patients with HIV. You can use cultures from blood, bone marrow, or respiratory samples to confirm your diagnosis, but remember that these may take weeks to result. Histopathology of affected tissue may reveal characteristic small 2 to 4 micrometer yeast cells. And in the case of a CNS infection or central nervous system infection, diagnosing histomeningitis can be quite challenging because CSF cultures are rarely positive. A CSF antigen or antibody test, if positive, is the most reliable way to diagnose histomeningitis. But oftentimes, a presumptive diagnosis may need to be made for histomeningitis if a patient has evidence of disseminated disease and also has CNS infection, and other causes of CNS disease have been ruled out or excluded. Okay, moving on to treatment of histo. The treatment for severe disseminated histo is divided into two parts. First is the induction phase, which tends to be a short period of intensive therapy, usually with intravenous antimicrobials or antifungals, followed by a maintenance phase, which is typically longer and with oral medications. The preferred medication for induction therapy is liposomal amphotericin B for the treatment of severe disseminated histo in people with HIV. The liposomal formulation of Ampho-B is preferred because it has been shown in trials to induce a more rapid and complete response with lower mortality rates and reduce toxicity more effectively than the standard IV Ampho-B deoxycholate. Treatment duration is a minimum of 2 weeks or longer if needed until patients have clinical improvement. Ampho-B lipid complex can be used intravenously as an alternative regimen for induction. After successful induction therapy, you can step down to maintenance therapy with oral itraconazole, and this should be continued for a minimum of 12 months. Now, if itraconazole is not an option for patients, alternative maintenance regimens include other azole drugs such as posaconazole or voriconazole or fluconazole. For the treatment of mild to moderate histo, you can skip the intravenous antifungal therapy and just treat with oral itraconazole. As mentioned in the last slide, alternatives to itraconazole are other azole drugs that are listed in this table. And just like with severe disease, you are going to be treating even mild to moderate infection for a minimum of 12 months. In patients with histomeningitis, initial induction therapy should consist of liposomal amphotericin B for 4 to 6 weeks, depending on symptom resolution and improvement in CSF findings. If liposomal Ampho-B is unavailable, Ampho-B deoxycholate may be used as an alternative. Following initial IV therapy, patients should receive maintenance treatment with oral itraconazole for at least 12 months. Voriconazole may be used as an alternative to itraconazole, and fluconazole is recommended for patients who are intolerant to both itraconazole and voriconazole. Most azole therapies for histoplasmosis require drug-level monitoring due to variable absorption and potential drug interactions. In this slide, I have summarized information regarding azole therapeutic drug monitoring. Starting with itraconazole, ideally you should use the liquid formulation of itraconazole as it is preferred for better absorption when taken on an empty stomach. That being said, the capsule form of itraconazole is better tolerated, and you can use that capsule form if you can achieve therapeutic levels with it. Serum itraconazole levels should be checked 2 weeks after starting therapy due to its erratic absorption and interactions with many antiretrovirals and CYP3 modulating drugs. Therapeutic levels are between 1 to 2 micrograms per ml. High serum levels that's greater than 5 increase the risk of adverse effects. Voriconazole and posaconazole are effective alternatives in moderately ill itraconazole intolerant patients. Vori trough levels should be checked 5 days after drug initiation, and target trough levels are 1 to 5 micrograms per ml. Voriconazole levels greater than 5 are linked to neuro and hepatotoxicity. Posaconazole levels should also be checked after 5 days to ensure adequate absorption, and the goal serum levels are greater than 1 microgram per ml. Moving on to antiretroviral therapy initiation. ART should be started as soon as possible. Azole drugs do have several drug interactions, so you should be aware of this when selecting an appropriate ART regimen for your patient. Immune reconstitution inflammatory syndrome, or IRIS, can be seen with histo, but it is not very common. In addition to symptomatic improvement, monitoring serum or urine histoplasma antigen levels is important for assessing treatment response, with testing recommended monthly for the first 3 months, then every 3 to 4 months until negative. Blood antigen levels decline faster than the urine levels, and polyene therapy, that is therapy with amphotericin, leads to quicker reductions than azole therapy. A significant rise in antigen levels may indicate relapse and the need to adjust your treatment plan. Long-term suppressive therapy with oral itraconazole is recommended for at least 12 months or longer after induction treatment for severe disseminated histo or CNS histo, or after reinduction for a patient who has had relapsed disease. Alternatives to itraconazole, which are fluconazole or voriconazole or posaconazole. But it is important to note that there is limited data for the use of these other azoles for long-term suppressive therapy. Suppressive therapy should begin once symptoms resolve and antigen levels decline. Long-term suppressive therapy may be safely discontinued in patients who have completed a year or more of therapy and have negative fungal blood cultures and a serum or urine histoantigen level that is below the level of quantification and a CD4 count that's greater than or equal to 150, and the patient is on antiretroviral therapy for at least 6 months or longer and have undetectable HIV viral load. Long-term suppressive therapy should be restarted if the CD4 count drops to below 150. Now let's talk about medication side effects. Amphotericin B is associated with nephrotoxicity and electrolyte derangements. Ideally, you want to use the liposomal formulation of Ampho-B to mitigate these side effects. You should be mindful of drug interactions with all of the azoles, and their use should be avoided in pregnancy, especially in the first trimester. QTc prolongation can be seen with fluconazole, vori, and posaconazole. Oral itraconazole solution may cause more GI side effects. Voriconazole has a narrow therapeutic index, which means that the range between the drug's effective dose and its toxic dose is very small, so vori requires close monitoring to avoid underdosing leading to treatment failure or overdosing leading to serious side effects. Posaconazole has to be taken with food in order to ensure adequate absorption. Finally, in summary, histoplasmosis is often a disseminated multi-organ infection in people with HIV with a CD4 count less than 150. Primary prophylaxis is indicated when there is increased risk of exposure to histo and the patient has a CD4 count less than 150. Diagnosis of histo is based on detecting urine histoantigen and or isolating organisms from blood, respiratory specimens, or tissue cultures, and or histopathology. The treatment for severe disease consists of an intensive induction phase with liposomal intravenous amphotericin B, followed by a maintenance phase with oral antifungals, typically itraconazole. Treatment is for at least 12 months or longer until the patient has a CD4 count greater than 150 and they're on suppressive antiretroviral therapy. ART can be initiated as soon as possible.
The production of this National HIV Curriculum Mini-Lecture was supported by grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA program and do not necessarily represent the official views of HRSA or HHS.